Excellent. Good morning, everyone. We are really excited today to have Dr. Andrea Conroy talk to us on the impact of AKI in malaria, all the way from Uganda. So Dr. Conroy is a PhD scientist. She's actually Canadian. She did her bachelor's in Guelph and her PhD as well as postdoc at UFT, working on biomarkers in malaria and immunology and immunity. Uh, since then, in about a decade ago, I think you are in Indiana. You have a faculty appointment in the Indiana University School of Medicine, but she is mostly working in Uganda, where we'll hear about her work there on AKI in malaria. Welcome.
Thank you so much. Yeah, I'm really excited to be here. I feel like I'm home. I'm from Ottawa, so great to be connected from a distance. So today I'm talking about AKI in malaria. I hope it's relevant to you, but also we can think about how these findings may be relevant outside the context of malaria. Okay, so I have no disclosures today, but I have many acknowledgements. So I wanted to start by just really recognizing the incredible team that I work with, from my mentors and sponsors, collaborators, many students and fellows, and our team here on the ground in Uganda. None of this work would be possible without them, as well as the children and families that trust us, as well as the administrators that support us. So my objectives for today, by the end of the talk, you should be able to define the incidence and etiology of acute kidney injury, or AKI, in children with severe malaria, be able to describe the impact of AKI on neurocognitive and behavioral outcomes in children following severe malaria, and then to also understand the long-term implications of AKI in child survival and kidney function following severe malaria. So just to orient everybody, in terms of talking about AKI today, I'm going to be focusing on the KDIGO definition, which is what we use in our studies. So an abrupt increase in creatinine within 48 hours or a fold increase within 7 days from known or estimated baseline. And while there is that urine output component, previous studies in the African setting have not measured urine output. So I'm going to focus on serum creatinine today. And then just to start with malaria, so focusing on malaria life cycle. So malaria is spread by the female Anopheles mosquito during a blood meal. And so here, just at the top, we have the mosquito taking its blood meal. As it injects saliva, it injects sporozoites into the body. These are going to travel to the liver, where they're going to invade hepatocytes and grow and replicate over about 2 weeks before they release thousands of daughter merozoites into the blood. And this is where we have disease and infection. So the parasite will grow and replicate within these red blood cells between 24 to 72 hours, depending on species, to release rupture, again, causing disease. A small percentage will go on to sexual differentiation to form gametocytes and be picked up again by the mosquito. Something that's really exciting to add to a talk is the fact that we have 2 WHO-approved malaria vaccines that are licensed, RTSS and R21. Both of these vaccines are targeting here, number 1. They are targeting the pre-erythrocytic stage and focus on these sporozoites that are going into the body. The vaccine administration starts at 5 months. It's a series of 3 doses. We just started in Uganda last month, malaria vaccination. So this is not a vaccine that would apply to travelers, but will hopefully be a game changer in endemic areas. So looking at species, I'm going to focus on Plasmodium falciparum here because that's the species that impacts people the most in Africa. So its replication cycle is 48 hours. You can see here, these are what the species look like under in the red cell. And then we have other species as well. So we have Vivax, which is very important globally, P. malariae, which can cause a nephropathy. There's 2 species of Plasmodium ovale. So these are 2 distinct species, but we cannot differentiate between them by blood smear. And then Plasmodium knowlesi, which is emerging as a zoonotic infection that's increasingly causing human disease in Malaysia. And what's notable about it is it has a 24-hour cycle. And so that is a replication and rupture of red cells every 24 hours. So it's extensive hemolysis and a large risk of AKI in null-zyme. So over history, malaria has touched us all. It's had a huge impact on the human genome. It's gone around the world through trade routes and it impacts basically every community or country historically. It's also impacted Canada. So 500 people died of malaria while constructing the Rideau Canal. And Plasmodium vivax was the single largest cause of death while building the canal. 60% of workers were thought to be affected. So definitely it has had its impact on malaria, Canada's history, but it remains a threat. So there is an average of almost 500 malaria cases reported in Canada per year, the notifiable disease, and most cases are reported in travelers and people who are visiting friends and family. In 2023, there were several locally acquired, locally transmitted malaria infections in the United States. Most were in the South, in Florida and Texas, but there was a case as far north as Maryland, and that was Plasmodium falciparum. So just thinking about this a little bit further in terms of Canada and climate change. So this map on the left of the country is looking at malaria vectors. So we have competent malaria vectors in Canada still, in southern British Columbia, and then in Ontario, Eastern Ontario, and Quebec. So certainly malaria can be transmitted, and there's significant geographic overlap between these vectors and our most densely populated cities. So there is potential for local transmission, particularly in the summer, especially with climate change. So then shifting focus, I want to look at global cases. So there's really major disparities in terms of the global impact of malaria. So in 2022, there were an estimated 249 million malaria cases. Cases in the WHO African region are in red. Nigeria alone accounted for 27% of global malaria cases, Democratic Republic of Congo, 12%, Uganda, 5%. And then when we go outside of Africa, the country with the largest number of cases is India, with over 3 million malaria cases every single year. So looking at malaria deaths, and these are deaths due to Plasmodium falciparum, you can see that it's really focused in on Africa. So this is these cases south of the Saharan desert, where we have the temperature and humidity capable of really efficiently transmitting malaria. So when we think of severe malaria, this is a life-threatening condition. It often occurs when there are delays in the recognition and treatment of malaria, and it presents with signs of organ dysfunction and injury. It requires hospital admission and treatment with intravenous antimalarial therapy. The most common is artesunate, followed by intravenous quinine. So this just image shows the different organs that are affected and some of the most common complications. There was a meta-analysis conducted in 2017 looking at the main predictors of mortality in African children. And they identified coma, acute kidney injury or renal failure, and acidosis as the most common predictors of mortality. Now, this is where we have a problem. So acute kidney injury has historically been missed in children. And the reason for this is the definition. So this is just a quote from the WHO severe malaria guidelines that were last released in 2014. As most patients with severe malaria are children or younger adults with normal premorbid renal function, a plasma creatinine over 3 milligrams per deciliter is used as a criterion of severe malaria. So 3 milligrams per deciliter. This is extremely high. This is extremely high for children, especially children where stunting is common, wasting is common. There is a high burden of malnutrition. So I joined forces with Anthony Batte, he's a pediatric nephrologist and my main collaborator, Terry Taylor, who's an expert in severe malaria, and Valerie Lux, who is a global advocate for kidney care, to write this commentary in Lancet Global Health, advocating for change in these guidelines. So we urgently need an update to these guidelines. So these graphs really show us why. So serum creatinine is on the y-axis, the age of the population is on the x-axis, the men on the left, women on the right. So when we look at the typical population ranges in creatinine, in green, you can see, as expected, they're much lower in children. When we apply a hypothetical KDIGO threshold, so 50% increase from those population ranges, you can see that it's quite a bit higher, but nowhere near that 3 threshold. Even severe AKI, so a 3-fold increase in creatinine, we're capturing some of the men, but none of the women, and certainly none of these kids that are under 5. So most pediatric AKI is missed using these current guidelines. We need kids to have a 10-fold increase in their creatinine before they're caught. And this is a huge missed opportunity to implement change. So updates are in progress, and we're hopeful that in the next iteration of these guidelines, there will be an update. So what we're doing about this is we're working on an individual patient data meta-analysis to look at the incidence of acute kidney injury and its relationship with mortality. So we've established this MACKID consortium, Malaria-Associated Kidney Injury and Disease Consortium, and we're doing an individual participant data meta-analysis. So far we've got data from almost 13,000 children with severe malaria. That may not seem like a huge number, but creatinine is not normally measured in African kids. And so this is a pretty great accomplishment. We've got a lot of groups coming together. We have data from 1993 to 2025. When we look at the incidence of AKI after the implementation of IDMS traceable creatinine assays, so this is post 2007, the incidence of AKI is 45%. So nearly half of children have AKI, compared to the 3% that the WHO says. And importantly, with 8 countries representing, we have over 50% of the global malaria burden in terms of cases and deaths included in this meta-analysis. So this is just looking at the studies, and we see that overall, there is a pooled odds ratio between AKI and mortality of 3.01. So a 3-fold increased odds of mortality if you have AKI. And there's no evidence of heterogeneity. Some of these studies are small, but everything looks consistent. Our next question was whether the results were generalizable. So we looked across age groups. WHO says AKI is more common in older kids, probably because their creatinine is higher and it's easier for them to meet that 3 milligram per deciliter threshold. We don't see any difference in mortality by age, by decade. It's consistent across region, whether it's East Africa, Southern Africa, Central or West, male, female, doesn't matter the methodology that we look to define acute kidney injury, whether a child is malnourished or whether they have severe anemia. It's a robust predictor of mortality. So this is what we're proposing, the simplified threshold. So we looked at, so these are all creatinines in milligram per deciliter, and we looked at the normal levels by children, by age, and then we multiplied it by 1.5-fold to get stage 1 AKI risk, and 2-fold to get severe AKI, so anything above that threshold. And then we rounded it to a single decimal so that we could have these age brackets. And what we're proposing is that if a child's in green, they're good to go. We give them standard clinical management, supportive care, plus an anti-malarial. If they're in yellow, we need to implement kidney protective care. So we're going to do additional monitoring, and we want to avoid any nephrotoxic medications, and we want to make sure the volume status is appropriate for that patient. Once we get to red, again, we want kidney protective care as our foundation. We're going to monitor and treat those AKI complications. And this is where we want to prepare for action. So we want to think about whether we need to transfer a child, whether they're going to need dialysis, engage nephrology early, and do anything we can to avoid the need for dialysis if we're in a region where it's not going to be available. So shifting focus on the etiology of AKI and severe malaria. So first of all, it's very similar to sepsis-associated AKI. So there's no major differences in terms of baseline risk factors. You're going to have hypovolemia and dehydration from severe disease, complicated by vomiting and diarrhea. It's an inflammatory disease, and there's pronounced microcirculatory dysfunction. But it is exacerbated by a high degree of hemolysis. Hypotension is uncommon. In fact, we often see hypertension in these children. And parasite cytoadherence and sequestration in the microcirculation is an important feature, and it's not addressed by fluids. So this is where you need to be careful, right? You think the kidney is not being perfused enough, but if this kidney has all these parasites sequestered in that microcirculation, fluids are not going to solve the problem. So oftentimes you start with treating the infection, conservative with fluids, and you wait and you watch and you manage those complications. So when we think who is most at risk, first turning to the Acute Dialysis Quality Initiative guidelines on acute kidney injury in low and middle income countries. So the QR code is there for this paper. So these are the signs and symptoms associated with AKI. So this is for both children and adults, but there's a lot of parallels between that and what we've seen in our malaria studies. So children in malaria most often present with vomiting. Children who are prostrate or comatose have a higher risk of AKI. Signs of hemolysis, particularly dark urine, which we call blackwater fever, or jaundice. If parents report low urine output, highly likely a child has AKI. Features of respiratory distress, particularly deep acidotic breathing associated with that parasite sequestration, is a sign of AKI. And children have a history of taking herbal medications, which is actually quite common. So we've looked at malaria and non-malarial acute febrile illnesses to see what the differences are. So this was a prospective cohort study in Jinja, which is in eastern Uganda. And we had about 1,000 kids, and we looked at kidney function. So AKI was defined using the KDIGO criteria. We assumed normal baseline GFR of 120, back calculated using an age approach, and then looked at the fold change. So what we see in this population is that actually AKI is very common, around 50% of kids, whether they have a non-malarial febrile illness or malaria. Severe AKI around 22%, doesn't change much, but we do see a difference in mortality. So when we look at everybody together, mortality in children with a non-malarial febrile illness or sepsis is higher than with malaria. That makes sense. We have good tools to treat malaria. Hard to know what the sepsis is. It's hard to know how to treat it. We don't have microbiology facilities to understand susceptibility and antimicrobial use. When we look at no AKI or stage 1 AKI, it's similar. Then when we look at severe AKI, things change. So there's a huge increase in malaria mortality once we get to severe AKI, and actually surpasses our sepsis mortality. So the question is, why is there higher early mortality in children with severe malaria-associated AKI? So I'm going to look at two potential reasons. So the first is looking at endothelial activation. So from this same cohort of 1,000 kids, we looked at pathways of kidney function, immune activation, endothelial activation in the plasma at the University of Toronto using a custom Luminex assay. So we took all of these markers and we standardized them. So this is important so that they all have a mean of 0, standard deviation of 1, and now we can directly compare patterns of changes between these markers where some may be high abundance, some may be low abundance. And so along the x-axis here, we look at whether a child has malaria, yes or no, and whether or not they have severe AKI. So what we see is in kids without severe AKI, there is a slight increase in endothelial activation, immune activation in kids with malaria compared to kids without. Severe AKI, as expected, we see a large increase in creatinine and cystatin C, which are used to define AKI. And then when we look at markers of immune activation, they're all elevated. Many of these are markers, proposed biomarkers of AKI. But the big difference is endothelial activation. So children with severe malaria have much more endothelial activation than children without. And this is important because those kids have parasites sequestered in that microcirculation. So the next thing we looked at was hyperkalemia. So we got data from almost 42,000 children who had been hospitalized at Kilifi County Hospital. That's on the east coast of Kenya between 1992 and 2016. So these data were generously shared by the KEMRI research group. And what we see is in Black, children with severe malaria are more likely to have a potassium higher than 5, 6, or 7 compared to kids with a non-malarial illness in gray. When we look by AKI, you can see it's even more striking. So hyperkalemia is much more common in kids with AKI, particularly if they have malaria. And so when we look at the impact on mortality, so this is looking at predicted mortality along the y-axis and potassium levels along the x-axis. There is a U-shape, so very low potassium and very high potassium are associated with mortality as expected. But what we see is that in this hyperkalemia range, mortality in severe malaria is higher than kids without, potentially because that is real hyperkalemia associated with hemolysis. And in the other group, some of that hyperkalemia may be pseudo-hyperkalemia from blood draws. So we think that improved recognition and treatment of hyperkalemia may reduce mortality in severe malaria. We're currently looking at this in a prospective study, but what we've seen is from the 1990s, mortality in hyperkalemia in malaria was 30%, fell to about 20% once we started testing for it in real time in 2010s. And then in our current study, it's down to 12%. And the biggest change is our early 6 to 12-hour deaths have really declined because we're aggressively managing that hyperkalemia. So just to summarize the incidence and etiology, we see AKI is common in severe malaria, affecting an estimated 45% of infections. These findings are consistent across space and time, associated with a threefold increase in mortality. Risk factors include hypovolemia and dehydration, hemolysis, and signs of other organ dysfunction. And severe malaria-associated AKI is characterized by more pronounced endothelial activation, and children are more likely to have hyperkalemia than children without malaria. And this is really exacerbated, both of those things, by hemolysis. So next, we wanted to look at the survivors. What's happening to these severe malaria survivors? So we've known for quite some time that children following severe malaria, particularly cerebral malaria, which is associated with a profound coma that's unexplained, it's not a postictal state, it's not hypoglycemia, and we rule out meningitis. Up to 25% of these kids are affected long-term. So they're going to have persistent neurologic deficits. Many of those will recover, but the more subtle changes in cognition, attention, memory, behavior persist. So we were wondering, is AKI contributing to this? So the way that we do this is we conduct psychological assessment tools on children. Much of this work was led by Paul Banjarana, who's a neuropsychologist here in Uganda. And this is Annette, one of our psychologists who's conducting a series of tests on a child. So what's really important is that these tools are adapted to different contexts globally and appropriate for use in Uganda. So we have translations, and then we need to assess to make sure the questions we're asking are culturally valid in this context. And if there's any adaptations required to ensure it maintains its construct validity. So is it actually measuring what we think it measures if we change any of these questions? And then it's also really important to account for confounders. So when we are testing these kids and we're looking at these, we need to adjust for socioeconomic status, which is going to have a huge impact on child development, parental education, enrichment in the home. All of these things are things we need to adjust for. So we send home visitors to the home to look at these interactions and to be able to capture this data in addition to what the parents are telling us. And so Paul has done a lot of work to ensure that we're using the right tools and that they've been translated for use. Okay, so just thinking, I just want to give you a brief overview of the tools that we're looking at. So in terms of cognition, when we're looking at younger kids, so under 5, it's really milestone based. But in kids over 5, you're looking at the ability to think, learn, reason, and plan. So for cognition, in the under 5s, we use a Mullen scale of early learning and look at fine motor, expressive and receptive language, and visual reception, which together create a cognitive construct that we're able to look at. And then in the older kids, it's the KABC2. And so then it's including learning and planning to assess cognition. And so we define impaired cognition as a z-score less than the -2 standard deviation based on our age range from community children. So those are kids from the same household, so that we're able to remove some of that variability in terms of enrichment and parental education. And so what we see here, so here we're looking at the relationship between acute kidney injury and cognition, so neurocognitive impairment, as a dichotomous variable. And so what we see is when we follow these kids at discharge, 1 year and 2 years, there's a significant relationship between AKI and neurocognitive impairment, even after we adjust for age, sex, nutritional status, enrichment, education of mom and child, disease severity during hospitalization, including the number of seizures, whether a child had a coma, and what they were treated with. So this is really a robust finding that seems to persist. We looked at some of the mechanisms, and I'm just going to touch briefly on one of them. So in all these kids who had cerebral malaria, they require a lumbar puncture. And so some of that CSF is stored for future testing. So we were able to look at the CSF to serum albumin index and to evaluate the integrity of the blood-brain barrier. And so we see that children with cerebral malaria overall, a substantial proportion of them have some disruption of that blood-brain barrier. Not surprising, given how much endothelial activation we see. When we look at complications associated with disruption, so all of these kids are in coma, we don't see a relationship between depth of coma or whether these kids are having seizures, but we do see that both AKI and having an elevated BUN, so that's higher than 20 milligrams per deciliter, is associated with a disrupted blood-brain barrier. That provides a plausible mechanism where AKI may impact long-term brain injury and function because you have a disrupted barrier, and so suddenly all these things now have access to the brain. We also looked at behavior in these children. And so again, these tools are adapted based on whether children are preschool or school-aged. And what we see is really major behavioral changes in children over 6 years of age. So here, higher numbers, so this is a regression coefficient, it reflects the z-score, a higher number is a worse outcome. And so what we see is that older children are more likely to have worse externalizing behavior. What this looks like when we look at the subdomains is actually aggressive or rule-breaking behavior. In terms of their global executive function, that is impaired. When we look at subdomains, it's really the ability to initiate tasks that seems to be impacted. And then when we look at behavioral regulation, it's really the ability to inhibit that behavior or to control emotions that's impacted. So in summary, we see that AKI is a risk factor for long-term neurocognitive impairment up to 2 years after recovery. And in children over 6, we see evidence of worse behavior and executive function with more externalizing behavior and challenges managing their emotions. We do see AKIs associated with a disrupted blood-brain barrier, and there's a lot of work going on at IU with my colleague Divya Datta and Chandi John to really understand that in much more depth generally, but then also thinking about AKI. So next I wanted to switch gears and focus on AKI recovery. So this picture is just looking at the intersection between acute kidney injury, so that abrupt loss of function, to acute kidney disease, which is that intermediate under 90 days loss of function, to chronic kidney disease, where the loss of function is persisting more than 90 days. And really an important outcome when thinking about long-term kidney function is a major adverse kidney event. And this can look different depending on the study, but overall, the main components is it's going to may or may not have hypertension included, the need for dialysis, chronic kidney disease, so incident chronic kidney disease based on either a low GFR with or without albuminuria, and then mortality. So there's been a lot of studies that have looked at what happens to pediatric AKI survivors. Many of them have been done in Canada. So BC, Montreal, Ontario, a lot of these studies have shown that after acute kidney injury, children are more likely to become hypertensive, they're more likely to develop CKD, and have albuminuria over the long term. So I'm just going to present the data from this one study that I think really does a great job of modeling that risk over time. So this is looking at a composite outcome of a major adverse kidney event in the first years after AKI using administrative hospital data. And what we see is that there's a very high risk, or the hazards ratio is very high in the first 4 years, and then it declines and kind of plateaus, levels out until about 16 years after, and then it declines. And these effects are really robust. It doesn't matter whether a child was in the ICU or not, whether they're a neonate when they had an AKI event or a child, male or female. There may be some difference in terms of cardiac surgery, but it's significant in both populations. Again, some difference in whether they were AKI was associated with malignancy, but significant in both populations, and the results are robust over time. So what about in low resource settings? These are children who are surviving an AKI event and frequently did not have dialysis in the first place. So what happens to their kidneys and those children? So I'm going to talk about 2 cohorts. These are both cohorts led by Dr. Chandy John, who's our division director at Indiana University. So the first study was from 2008 to 2013, 500 children with severe malaria. These kids were followed for 24 months. And then the second study was in 2 sites in Uganda, so Kampala, which is here, and Jinja to the east. 600 kids with severe malaria followed for 12 months. So we looked at CKD following AKI. So this is study 1. These kids are a little bit older. 35% had AKI in enrollment. When we looked at CKD based on a GFR less than 90, so a 25% reduction in GFR, we see our community children, our prevalence is around 2%, 2.8 in kids without AKI, severe malaria survivors, and goes up to 7.6% in children with severe malaria and AKI. Now, we weren't able to look, these samples were tested after the study completed. These kids did not have follow-up, and we weren't able to confirm after 3 months whether this was true CKD. Next, in study 2, is a bit of a different design. So now we have a follow-up visit at 1 month. So we're not following them we don't have kidney function long-term, but we can look at that short-term recovery. So we have 600 kids with severe malaria. They're 6 months to 4 years. At 1 month follow-up, we assess kidney function. 45% had AKI during hospitalization. 16% had persistent kidney disease, or AKD, at 1 month. And so looking at this graph, this is looking at post-discharge mortality. So kids with AKI are in red, no AKI are in white. When we look kids with no AKD, there's a 2-fold increase in mortality in AKI, but generally it's fairly low. But when we look at kids who had an AKI episode, still have AKD, so they have not recovered, post-discharge mortality was 18% in this population. So then we wanted to look truly long-term. So we combine these cohorts. There's over 1,000 children with severe malaria from these 2 studies. We tracked these kids down, reconsented, and there was a huge battery of tests. Many of them were focused on academic achievement, economic, mental health, like a lot of different factors, but focusing on the kidney recovery, we assessed kidney function. Anything that was low, we actually followed up and had those kids go to a nephrologist to assess their kidney function and to repeat. So overall in this population, we have 40% with AKI. So we looked at our major adverse kidney event. So this was low GFR, albuminuria, or mortality over follow-up. And we used the KDIGO CKD color classification to put our kids into those different risk zones and look at these outcomes. And when we look at kids without AKI and then kids with AKI, we see a significant difference in the MAKE long-term outcome. But it seems like much of it is actually driven by this mortality in black. So not a big difference. And actually, it doesn't seem like there's much difference at all in terms of a red or orange, so CKD risk, but we're seeing a lot more mortality in that AKI group. So looking at mortality further, we see overall mortality is much higher in children with an admission AKI compared to those without. So this is looking at overall. And then when we look at in-hospital mortality, you can see, as expected, that's going to be much higher. We see very similar numbers when we look at these kids as we follow them long-term outside of the hospital. And so this is looking at the cumulative survival in these kids. And we're seeing that in kids with AKI, only 60% of them are surviving long-term. So we have a huge difference in mortality in these kids over follow-up. Again, looking at this, so Cox regression, this time we're adjusting for disease severity. So we are adjusting for age, sex, nutritional status, study site, the cohort, because we're now combining them, HIV, as well as hemolytic complications, anemia, because post-discharge anemia can be a big confounder and be associated with mortality. We have a 3.4-fold adjusted hazards of mortality over 5 to 15 years follow-up. So we then conditioned it on surviving the initial hospitalization. So now we've taken all the kids who died out of the picture. Still, we have a 1.9-fold increased hazards and mortality. Okay, well, what if we get rid of those early deaths, right? Among the kids who survived up to 1 year, you'd think that their risk would be very low at that point in time. We're still seeing a similar picture. They have higher long-term mortality. When we look at kidney function, so this is just looking at the estimated GFR. So this is the enrollment. Of course, the kids with AKI have a much lower GFR. But when we look at their follow-up visit 5 to 15 years later, there is a difference, but it's not striking. And among the kids who have lower GFRs, we're not looking at people who have progressive or advanced chronic kidney disease. We modeled this using linear mixed effects models. So this is an adjusted model where we're again counting for age, sex, site, study, and long-term follow-up. And we see that the difference is there at the beginning, but when we adjust for all the other factors, they really come together by 1 year follow-up. So we're not seeing a major change in kidney function. So in summary, while findings from Canada, from children with severe malaria are consistent with cohorts and the administrative data from Canada, children in high-income settings are more likely to develop chronic kidney disease or hypertension. And yet in Uganda, we're seeing disproportionate mortality. So we hypothesized here that this is related to repeated AKI episodes and driven by a high underlying burden of infectious diseases that puts these kids back in hospital and puts them at risk of repeated AKI episodes. So overall, in summary, we see AKI occurs in 45% of children hospitalized with severe malaria. It remains underappreciated due in part from our definitions that we're using. The etiology of AKI is similar to sepsis with a few key differences. We have extensive intravascular hemolysis in malaria, more pronounced endothelial activation, more structural injury to the kidney, and hyperkalemia. Hypertension is more common than hypotension. Survivors are at risk of neurocognitive and behavioral problems. It's associated with increased long-term major adverse kidney events, but this is really dominated by mortality, not CKD. And I think that's a little bit lost when we use a composite outcome that incorporates both. So I just wanted to briefly touch on our ongoing work and future work. So this is, again, Dr. Anthony Bate, who's the site principal investigator for this NIH-funded R01 study. It's a multi-site study across 3 sites, including northern Uganda, to really understand regional differences that differ by malaria transmission intensity, to look at the incidence of AKD and CKD after AKI with severe malaria. So it's a hospital-based study. We enroll anybody with severe malaria. We follow them rigorously. We're getting urine output, serial creatinine measures. We're doing AKI biomarkers, real-time and later testing. We follow them at 1 month, 2 months, 4 months, so we can define CKD, and then 1 year and 2 years. So we're doing all of that, and then we're doing really comprehensive evaluation of health-related quality of life, cognition, behavior, and then Anthony has a Fogarty Award from NIH, and he's looking at the brain injury component, the brain injury biomarkers, also doing MRIs in these kids, pre and post dialysis, and at recovery. So I think we're going to have some really interesting data coming from that, and really focusing on the incidence of AKI for these kids who keep coming back sick to the study, and looking at what those pathways of maladaptive repair are in malaria and whether they're differing from other causes of AKI in children. So just finally, focusing on the global context, 85% of our global AKI cases are occurring in low and middle income countries, where infections and malaria are important causes of AKI. The data we have on long-term outcomes following AKI suggests we need really a lot more investment in identifying context-appropriate solutions that focus attention on AKI, provide education on recognition and treatment, giving us the tools to identify and management, and looking at new treatments that are appropriate, both high-income settings, but then also in low-income settings where the same approaches may not work. And with that, I'd like to acknowledge my funders and take any questions.
Fantastic. Thank you for that excellent overview of a topic that many of us know very little about. So I'll open up the talk for questions. So, there's a question from the conference room already.
Hi, thank you very much. Sorry. My name is David. I'm one of the adult nephrologists. I agree this was a really great talk and very enlightening on something that we don't really see much and we don't think about much, but that obviously is very important in other regions of the world. So thank you for coming to talk to us about this. I really appreciated it. I have a question regarding podocytes and APOL1. You know, you didn't mention that AKI or kidney injury in malaria seems to have any kind of glomerular involvement. You did talk about endothelial activation, and you know there can be a crosstalk between the endothelial cells and the podocytes. And I just wonder if it's been looked at, if maybe children that have worse AKI, if there's underlying APOL1 could be playing a role, and also in long-term complications after, although you did mention that it's not so much CKD, but more the mortality, the long-term. But I just wonder if that's been looked at, because it is in a region where obviously it's more common to have APOL1 risk alleles.
Yeah, that's a great question. And so we actually have looked at that. It's pretty exciting. So Uganda is actually the only country that has both species of trypanosomiasis. So it has both East and West African. So we thought it would be really interesting to look at. Overall, the prevalence of APOL1 risk alleles in East Africa is much, much lower than in West Africa. And so the studies that have been done generally in East Africa have not shown the same thing as studies that have been done in African American populations or in West Africa. What was interesting, so we did see a low prevalence of risk alleles overall. You know, we're looking at 1,000 kids, which is a lot for our context, but not a lot for genetic studies. And we see that 80% of our kids with APOL1 die. So APOL1 risk alleles, 80% of those kids die during follow-up. That's actually as high or higher than our kids with sickle cell disease. So as a comparison, because that's really what we think about as the largest kind of genetic contributor to chronic kidney disease and early mortality here. So they seem to be comparable. So I think it's really interesting to think about the intersection of these parasitic diseases of trypanosomiasis and malaria. We don't know why, and it's you know, a relatively small study, but that's something that we do hope to follow up on in our ongoing study to see if we're seeing similar things.
So sorry, did you say 80% of children with high-risk alleles for APOL1 that get malaria will end up dying?
In our study, that, yes.
Oh, that's huge.
So I think that's the first time we've seen it. We looked at a population-based study to see if there were age-related changes that would explain that, but it's not clear. So we're not really seeing a CKD phenotype associated with APOL1 in Uganda, but certainly the high mortality we see raises questions and is something we'll follow up on.
And is that dying of like acute malaria and kind of the immediate complications, or kind of in the short, longer term follow-up after?
Yeah, so it's over the entire duration of follow-up. So we do have a relatively small number of kids who have the high-risk allele, but 80% do die. It's hard to ascertain cause of mortality, particularly once a child goes home. Oftentimes they die before they make it back to hospital. Many of our deaths happen at home or on the way. We do verbal autopsies on these kids, and most of the time it's related to an acute illness or a fever or an infection. So it could be a similar story of they're more susceptible to infections and mortality associated with infections when they do get them.
Well, thank you. Thanks very much.
Yeah, thank you. Dr. Reen?
Just to expand on the question which was from your room, I have actually a couple of patients which I followed, still following them, and they presented with severe acute kidney injury requiring dialysis and admitted in ICU. They were both from Ghana, and they both had APOL1 positivity, and they do become hypertensive very early. I've been following them between 2 to 10 years. So we have a number of patients we see where I practice, which is in GTA and Brampton, Etobicoke area, and we have a lot of immigrant population, and we do see malaria. And for some reason, the people who come from India, that doesn't reach a nephrologist. And I know that they come to emergency followed by our infectious disease person, but people coming from West Africa actually have a severe disease. And I'm convinced if we continue to follow them up closely, most of them will be APOL1 positive. My both patients, we did biopsy one who had collapsing glomerulonephritis with a cytokinin storm and was treated with anti-malaria and came off dialysis. But she became hypertensive. She was 22 when she had this episode and became hypertensive after now she's 27. And similar cases I have seen in dengue from Caribbeans, from Jamaica especially, and they follow the same pattern. So I think phenotype does play a role.
Thank you. Dr. McCarthy.
Hi, sorry, I just got on, so I don't know anything about the case. Was this a malaria or a falciparum case? The malaria. Or did I miss completely?
That question is for me?
Yeah, I guess you can answer because we were talking about your patient. Yeah, with the collapsing FSGS.
Yeah, collapsing GN with the APOL1, and it was malaria falciparum.
Oh, it was falciparum.
I actually writing that paper up. I'm hoping to publish it. So I think it's an important thing. Actually, it was reviewed by Dr. Rulan Parekh, who you quoted in your talk, Dr. Conroy, and she's involved in that care and following that. So malaria falciform, both patients were report positive to malaria falciform.
Okay, just with your story of the other patient who you treated for malaria, it sounded like you can get a chronic malaria that's well associated with renal problems. With malariae, people can have that malaria for up to 20 years. So that's why I asked. But like I said, I apologize. I couldn't get in, so I missed the whole thing. So
yeah, they can get membranous glomerulonephritis. You are very right. And I can tell you, I haven't seen any patient of membranous nephritis related to malaria. And I actually specifically asked, did you have malaria in India? So there are no markers. I can't prove it to you that because there are no specific stains like NEL1 and exotin 1 and 2 and other things. But I can tell you that I haven't found one, but it has been described. The problem is that these people have not been biopsied that frequently. That's the issue.
So just as a teaching point for all you guys, if ever you think of it, malaria is very hard to find. So I would talk to hematology and get a PCR. Very easy to treat with chloroquine. So you can get rid of it very, very easy. But, you know, so if you're thinking about it and you, rather than wait, you'll probably never find it on smears because it's so low. But anyway.
Yeah.
Okay. Thank you.
Yeah, thank you for that, Dr. McCarthy. If there are no other questions from the rest of them, I can ask a few. You started off, Dr. Conroy, with the Rideau Canal story, where so many people died in Ottawa from malaria. How did we get rid of it? Or was that just, and how did we get it in the first place? No?
Andrew, if you don't know the story, I do. So go ahead.
I mean, I'm not sure if I know, like, I think much of it was environmental of targeting mosquito populations. I know in the US they did a lot of bed nets and they were able to kind of get rid of it that way. And I think after the canal was done, a lot of, the people in that high risk exposure of being close to the water really declined. But Anne, I don't know if you want to add more details there.
Sorry.
Yeah.
It was actually as they dug the Rideau Canal, and it was soldiers who had come back from an area where there was vivax malaria. So even though we don't think of vivax as deadly, it can be. And we do have anopheline mosquitoes here. They're not great. And as you know, they don't stick around. So there were some cases around that area, like you said, Andrea, but just with, I think, mosquito control practices, and I think they had chloroquine at that time, so they would have been able to take care of the blood stage. I doubt we had primaquine, but there's actually, I don't know if you showed it, there's actually a monument to when they got rid of malaria in this area as they dug further down in the Ottawa Valley. I can't remember the town. So
yeah, that's something we should find out. So another quick question for you. You mentioned the 45% AKI in kids. With the criteria that you guys used. Do you think there could be some element of selection bias in the fact that only people who had severe AKI got their creatinine measured? Is that possible, or was it is there something that was more random in terms of how the creatinine was being measured?
Yeah, I think definitely there is a potential for that. We excluded any studies that were, nephrology-based studies and where they were looking at AKI. And so all the studies that we included were really large observational studies that were fairly inclusive. A couple were focused on cerebral malaria, so definitely they're going to be maybe a higher incidence of AKI in that population. But the one from Kilifi in Kenya that had 8,000 kids with malaria, that was routine testing of every kid over a period of 30 years. And so, there are the issues with the assays and like pseudochromogen interference with malaria from the Jaffe assay before we had IDMS traceable assays. But I think that is reflecting the true incidence, and that's all encompassing. So that's including stage 1 AKI. If we're looking at more severe, then we're looking at between 20 to 35% probably have severe AKI.
Yeah, that does make sense. That's useful to know. And again, going back on the selection bias issue, right? With the CKD, the fact that CKD is so uncommon in the follow-up in your studies, do you think it's some kind of a survivorship bias? Like, the people who survive severe AKI are those who are, otherwise very healthy, which is why you see lower CKD. And those who would have gone on to develop CKD probably just died because of, the severity of malaria and the other infections that are seen. Again, very speculative, but have you got any thoughts around that?
Yeah, I think there's probably an element to that. And when we do have those kids from that CKD assessment at 1 year follow-up that did have evidence of CKD that we followed 5-10 years later, they did still have a lower GFR, but most of the time it seemed pretty stable. It's under 90. Sometimes it, went from 90 to 80 to 70, but there's no evidence of rapidly progressing CKD. And when we do look at the mortality and we look at the kidney function at for each interval where we're following kids and we're assessing mortality, and we look at the kidney function in that preceding that interval, so kidney function at 1 month or 1 year, the children who die after that period, at every time point, they do have lower kidney function. So I think it is probably kids don't survive with CKD very long. And I can say even from our study now, we've had at least one kid who had dialysis, went on to develop, or their kidneys never recovered. And so they had chronic kidney disease, persistent hyperkalemia, but they stayed very far from Kampala. And so when they would require treatment, they would go into the hospital. And ultimately, they died. If you look at the child's weight and the fluid status, this child had end-stage kidney disease when they died, but the cause of death was pneumonia. So, I think a lot of them, I think CKD-related deaths, when it's rapidly progressing, may be attributed to infections in many cases as well. So we need to be better at recognizing that.
Yeah. And I'm assuming that, when there is severe malaria, they are getting the right treatment. So they develop AKI despite that. So maybe we should focus more on, just as well on prevention. How I know the vaccines were approved. How good are they? And are they being rolled out?
Yeah, so they are being rolled out. So 90% of our AKI is community acquired. So definitely the answer is prevention and treatment to save the kids' lives who come in. And so I think, we're focused on that aspect, but prevention is really critical. The vaccines are okay. They're not what we think about when we think about a highly efficacious vaccine that is just going to give you sterile immunity. They reduce disease severity. They're going to reduce mortality and the number of clinical malaria episodes. And I think that is really important in our populations, and has the potential, when we think about the impact of malaria on the kidney and the cumulative impact of malaria episodes and AKI events over the course of a child's life, and what that means for the country and what that means for CKD, I think it's going to have a huge impact. So we'll wait to see. We just started vaccinating in March. So we'll see what happens in Uganda over the coming years. Hopefully it's enough to override the disruptions to malaria prevention programs that we're facing.
Yeah, it's kind of unfortunate. We hope the funding continues to, this is such a huge issue that we hope these vaccinations continue. So it's the end of the hour. Thank you again for the excellent overview of the topic for us. And, you're an Ottawa native, so maybe the next time you make a trip here, we can meet in person.
Yes, that sounds great. Thank you so much for having me.